Good. Good morning, dear delegates and respected Dr. Ram Gulati, sir, and my colleagues, Dr. Vipul Jain, and our President, IIP Delhi, Dr. Anurag Agarwal. I welcome all of you to the first session of Certificate Course in Pediatric Dermatology. Now I request Dr. Anurag Agarwal, our President, to say a few words, and we begin the session.
So good morning, friends. Nice to have you all on a Sunday morning. And the strength is rising continuously. I can see around 370 participants already, and the ticker is going up and up. So we shall touch our figure of around 900 registrations, Dr. Ajay?
Yes.
So Sunday morning is usually a time for leisure, but looking at the interest in young pediatricians in the topic of dermatology, it's really nice. And we at IIP Delhi shall be doing many such more modules for the younger lot, for the practitioners, for the residents. See, dermatology is around 20 to 30% of your OPD. And we need to recognize all the kinds of lesions which we get, and we need to treat them also. We should also know when to refer. And of course, dermatological signs are harbingers of lots of other chronic diseases, and they are signs pointers towards other ailments also. So looking at that, a pediatrician should know a good amount of dermatology so that he is successful in his practice and is able to provide best care to the patients. Having today's topic, atopic dermatitis, is very interesting. I think Dr. Ram Gulati will tell you the incidence, but I expect this to be present in around 5 to 8% of pediatric population, maybe more. Dr. Ram will be telling you more about it. Something which is very easily treatable, requires chronic continuous treatment and a motivation from the pediatrician also, because you see, all the patients first come to a pediatrician and first 2 lines of treatment are to be given by the pediatrician. So how to manage these conditions and how to move ahead in life is very important for the patient as well as for the doctor. So having said these words, I welcome you all to this module. Happy learning. Enjoy the module. Do give us a feedback. What better can we do in the future modules, because you'll have many such more modules coming up over the years. And IIP Delhi is always ahead in academics. Again, please become members of Central IIP if you are still not members. It is our parent body, and you as pediatricians shall be its member, shall get lots of information, the journals, the activities, the other modules also in which you can participate. So please become members of Central IIP if you are not members. And having said that, I hand over the podium, the mic back to Dr. Ajay. Thank you.
We welcome Dr. Alok Bhandari, sir, our incoming president, and Dr. Pankaj Garg, our president-elect. And we begin the session immediately, and then we'll have the discussion. Request Dr. Ram Gulati, sir, to please begin the session.
Dr. Ajay, can we have a word from Dr. Alok? Just one word.
Sure. Dr. Alok, sir, you want to say something?
Well, good morning, friends. Welcome to this initiative of IIP Delhi. And as you know, Delhi IIP is known to maintain punctuality in its sessions. So I will not speak anything else than welcoming you to this module and happy learning. And let's go ahead. Dr. Ram, please carry on.
Thank you, sir.
I request everyone to please keep their audio on mute. Thank you.
Okay, thank you very much, sir. So wonderful good morning to everybody. That's what I was telling you beforehand. So it's a holiday, but I think a couple of hours in the morning actually is always good, even on a holiday, to keep you going. Atopic dermatitis, I think as such, if we consider the disease or disorder, it probably is worth a complete day seminar rather than a small half an hour, 1 hour thing. The most important thing to know is, how to manage atopic dermatitis, and at what extent do you feel that you need to rope in a dermatologist, and that is where the question arises. But as has already been told by Dr. Alok, Dr. Ajay, that the pediatricians are the first line of call. So because the families have got a great rapport with the pediatricians, they go in and out many times in a year for many reasons, and therefore when something happens on the skin, it's always the pediatrician who is the first line to go rather than a dermatologist. So if you look at atopic dermatitis, go into the epidemiology, you look at the world incidence. In developed countries, almost up to 20% of the children can have atopic dermatitis. But it varies anywhere between 3 to 4% to almost 20% if you look at our country's length and breadth. And it is slightly more, you can see in the northern part as compared to the southern part. But you probably need kind of more studies which can probably completely span the area to come to a conclusion as to where we stand. But as development, it has almost reached kind of a plateau where they're about 20%. But in developing countries, it is seen that the incidence is now increasing. So how do you define atopic eczema? I mean, once you have seen atopic dermatitis children, now atopic dermatitis and eczema is synonymous. So we'll go with that. So when you see atopic dermatitis, once you have seen a few children, then you don't have to go into the criteria as to whether it is there or not. But then the most important hallmark that you see up there is itchy skin condition. So if the skin is not itchy, then you can very well rule out atopic dermatitis. The one classification, the one criteria which I presented here on the screen is the UK Working Party criteria. And this came quite late. So initially we had the criteria called Hannifin and Rajka's criteria, which used to have 4 major and around 23 minor criteria. So they were very good from doing studies or looking at the statistics, but then it is very cumbersome to actually see. And many of them were minor criteria, which could be seen only in a few handful of children. And then came the American Academy of Dermatology. They tried simplifying it. The UK Working Party criteria is quite a simplistic criteria. Again, for studies purposes, it might not be the best thing, but then if you want to define atopic dermatitis, what it says is the most important conclusion that we and then it says that 3 or more of the following 5 you can fulfill because of atopic condition. And what it says, it has to be a dry skin in the last 12 months. Then it relies on the history. So there's a personal history of dermatitis, there's a history of other conditions like asthma or allergic rhinitis, and the onset is under the age of
Dr.
2 years.
Gulati, can you stop the video of yours because voice is breaking in between? Maybe once we stop the video, the bandwidth would be enough for the audio.
Please switch off your camera.
Should I stop?
Stop.
Switch off the camera. Stop
Camera.
the video.
Yeah,
Camera.
perfect.
That's it. Thank you, sir.
See, does that help?
Yes, sir. Yes,
Now
sir.
it is
Let me
perfect.
know how the
Now it is good. Now it is good.
Thank you. So if you look at the criteria, so 3 or more of the following plus an itchy skin condition. So it is relying largely on the history and then one aspect of the examination, which is a visible flexural dermatitis. But if the child is below 18 months, then instead of the flexural, involvement of cheeks or the extensor would do. So that is what atopic dermatitis, how you can classify atopic dermatitis in a simplistic fashion. Why cheeks and extensor early on is, look at, let me go ahead. So if you look at the infants, how they present with atopic dermatitis, it presents quite early on within the first 2 to 3 months of age, and cheeks are usually the first areas to be involved. Now, there are a lot of studies which are looking into the pathogenesis as to why the cheeks. They have come to a conclusion that there are pathogenic factors here which contribute to development. I would not go into the details of the pathogenicity. So what we can say is that it starts at the cheeks and then it can get distributed. But usually you can see that the napkin area is spared. Now that area is spared mainly because the hypothesis is that there is a lot of moisture present in the napkin area. And many a times what you can do is you can show to the parents that see what a moisturizing can actually do to a child's skin by showing the napkin area that it is completely spared because of the moisture. Again, when we think of atopic dermatitis as an itchy skin condition, one has to be very wary of neonates where they are not dexterous enough to actually scratch. So you would not see scratching as such. And if there is some kind of a physical weakness in the child, they may not be able to scratch. So in those children, itchy has a different connotation. Now the area is going to look dry, red, scaly, and there will be excoriations because the child has scratched the area. So if you look at the next photograph, you can see that there's a very ill-defined erythematous area where you can see some crusting is there and some erythema is there. And if the scratching goes on, then you start seeing these excoriations. So there are areas where the skin has been taken off by the nails because of the scratching by the child. And eventually, if the skin is open for a while, you can probably get secondary infection in that, and you can see yellowish colored crust. And mostly it happens when you see yellow crust, but there can be strep involvement as well. So staph and strep are the commonest ones, but the children with eczema on an average, on the whole, are heavily colonized with staphylococcus as compared to individuals who do not have atopic eczema. So there is some problem with the antimicrobial peptides on the skin as well that is causing heavy colonization by staph aureus. Now, as the child grows and they go into toddler age group and the preschool age group, they become more mobile. And therefore, what you see is that it is considered that initially the extensor area is involved. So you can see eczematous areas on the elbows and the knees. That's mainly is considered that mainly because the child is crawling. So they actually get friction. And because of that, maybe it opens up some antigens that cause external eczema. And eventually, as the child is beyond it, you will start seeing the flexural involvement. And again, it is seen the elbow folds, the knee folds, and the neck fold. And the neck fold is known as the dirty neck of atopic eczema because repeated eczema in the area of the neck makes the neck look very dirty. What you can see here in the diagram is the elbow texture. And you can see that there are a lot of excoriations because it is scratched. And if you look at the central skin, it is thick, it is pigmented, and you get the markings that are slightly more visible, and that is because of the of the skin. And this whole process is called lichenification. So lichenification is that once you have rubbed it for a long period of time, the skin looks thicker, the skin looks pigmented, and you can see more skin marking. Now, just below the eyes, you can see the presence of very prominent folds, Morgan folds. Again, one of the hypotheses is that because of the rubbing of the eyes, causing a thickening of the eye folds. You can see the flexural of the upper eyelid sometimes as well if there is involvement of the extraneous airborne allergens. They can be involvement just behind the earlobe.
I think he got disconnected. Screen is visible, sir, now.
Visible?
Yes, sir.
Are we on the slide where the eyes and the hands are there?
No, sir, it's frozen on the first slide.
I think I just take a while. It'll just come up.
Huh.
Is there?
Not right now, sir. Just take few seconds.
I mean, the question and answer, there is a question there which says, is crisaborole cream for local application in pediatric patients? If so, how?
So your screen is visible, not the presentation. So can you please log in again? That will help.
I'll just do it again and see if it works.
Sure. Yeah. Yes, sir. Screen is visible now.
Yeah.
Yes, sir. Now the screens are moving.
It's moving.
Yes. Cheek photograph is showing.
Right. Probably is on the eyes one now.
Elbow, the cubital fossa is showing. Toddler and preschool.
Yeah, it'll just come on the next one.
Yes. School children. And the
Yeah. So,
yeah.
so it's in the school children, actually, as the child grows, you see more of the flexural involvement. And the round one which you can see is known as a discoid eczema. So I changed the network. I'll just be back in it.
Screen is visible. Yes, sir. Eyes are visible. Sir, please switch on your mic. Dr. Gulati, please switch on your mic. You're on the mute.
Is it okay now?
Yeah, sure.
Yeah.
Thank you.
Sorry. So as a child grows, you can see more of the flexural. The discoid eczema are usually more stubborn kind of an eczema. So the moment you see actually kind of an annular lesion, but this is not completely annular. So you can see that the central area is actually affected as well. So you can differentiate it from tinea, which is again it's a fungal infection. But in tinea infections, usually what you see is an annular ring and the central clearing. But here what you can see, there is no central clearing. So these are discoid eczematous lesions, which are completely filled up with the eczematous area. In the central area, you can probably see one area which is the dorsum of the foot. Now, and on the left side, you can see the hands which are affected on the dorsal area. So the photograph of these hands is from the COVID times when there was excessive use of sanitizers, and this is an irritant eczema rather than atopic eczema. Now, what is irritant? So atopic children have got drier skins, so they are more prone to get an irritant eczema if they are getting exposed to an irritant substance. So these children who have got a background atopic eczema or a dry skin, they tend to get more irritant contact dermatitis than the children who do not have atopic eczema. Now, many of the atopic dermatitis will grow out. So that is kind of a ray at the end of the tunnel. For milder eczema, usually the parents are not that worried. But for children who have got severe eczema, the one question that always comes from the parents is, when is the eczema going to end? Now, children with actually moderate to severe eczema, they are more likely to last longer than the one with mild to moderate eczema. And it was said that almost 50 to 60% probably are going to grow out, but that percentage is probably getting smaller day by day. So if you see this child, now again, you've got eczema almost all around the body. So it is a complete trunk involvement and the limbs involvement. So it's kind of a generalized eczema. which is there. So the photographs are just to show that you can have a variety of involvement, from a localized eczema affecting maybe only the folds or maybe the infraorbital area, and up to a point where almost the whole skin gets involved with dermatitis. Now, before I move on to the management, the question comes, do we have any kind of a laboratory parameter by which we can diagnose atopic eczema? So as we have already seen, the first slide, which was criteria for diagnosing atopic dermatitis, which was itchy skin condition with 3 of the 5 things that we saw, it is a clinical diagnosis. So it is not a laboratory diagnosis. Now, most of the eczemas, they can be considered as extrinsic eczema. That means they can be role of the environment to a great extent. And in these eczemas, you see that the IgE is usually found to be high. So in majority of the children with atopic eczema, you will find a high IgE. Now, IgE as such was shown to have little role to play from the diagnostic perspective or therapeutic perspective, but increasingly we are realizing that it may be one of the biomarkers we may rely on in the future and see. So IgE, if it is done and if it is high, then you can definitely have an atopic background and you can try defining atopic dermatitis as a possible association. So how do you manage atopic dermatitis? See, there's a lot of bullet points there. So you can see about 9 or 10 of them. So the general measures, even though it says just one and then emollients, topical steroid, general measures have a lot of role to play. So what the environment of the child should be, what kind of a clothes should a child wear, what kind of a, I'll come to the diet later on. The next is emollients. So emollients is the mainstay of management of atopic dermatitis. So when you write a prescription, I think the first thing there should be emollients. Without an emollient, the prescription of atopic dermatitis should not go. Steroids and calcineurin inhibitors, which are pimecrolimus and tacrolimus, they are something that is used as needed basis. There is another way as well called proactive therapy. I'll go through it, but these are something which are not for constant use. There are many times you see prescriptions where you see a steroid mixed with a moisturizer being used on the entire body for a long period of time. It may give some kind of an immediate relief because you're putting an anti-inflammatory across the body, but that is not the best way to use a steroid. So the steroid needs to be used only on the affected area intermittently. Antihistamines, again, it is only the first generation antihistamines which are largely useful because of their sedative properties. The non-sedative ones, they may help in mild to moderate itching, but usually in severe eczemas, you don't see much response from them. Again, antihistamines are not for a long-term use. They are for a short-term use only as a salvage in times of crisis. Phototherapy, wet wrapping, systemic immune suppressants, they come largely into the dermatology domain where you will need to liaise with the dermatologist if the eczema goes beyond moderate to severe. Oral steroids, even though there is a small slide on oral steroids afterwards, they usually are only a short kind of a course as a bridging therapy. If, for example, the eczema is bad enough that it is not being controlled with rational measures of topical therapy and antihistamine, you probably need to go on a systemic immune suppressant. And because almost all systemic immune suppressants have some kind of a latency period before they start acting, we can give oral steroids in that short period as a bridging therapy. I think oral steroids are much more used in acute asthmatic crisis as compared to the eczematous crisis, because in eczema, once you put an oral steroid on, sometimes it is very difficult to actually get off the oral steroid. So, and this is an important slide because first consultation. So at first consultation, what you need to do is you need to educate and counsel the family. Now, first consultation of an atopic eczema on an average will take around 15-20 minutes at least. And that will ensure that the parents are made aware of the various things that they need to take care of, and they do not come to the doctor again and again for very minor things. Now, first of all, is involve the parents and the other caregivers, because the child by himself mostly will not be able to actually put many creams on, and usually they are carefree people. So children, as you know, they don't have time to actually do things. So it will be the parents and the caregivers who are going to actually apply the creams and the moisturizers. Second, you give sufficient time to explain the chronic nature of the disease. Do not ever put a deadline. It is not uncommon to see parents who are coming saying that somebody told them that by 5 years of age the child will be absolutely fine. So do not put a deadline to it. Say the chances of getting eczema sorting out by itself is high if the child has mild to moderate eczema, or maybe it will take a longer time if you have got moderate to severe eczema, but do not put a deadline. And do emphasize that it is very natural for the atopic dermatitis children to have a few flares in the year. About 5 to 6 flares is not uncommon, because usually you will see that the eczema flares at times of infections. So if a child has got fever or runny noses, or you got upper respiratory tract infection, or get diarrhea, during those episodes when there is inflammation in other areas of the body, you will see that the eczema flares as well. So at that time, just maybe increasing your therapeutic armamentarium stuff and just putting maybe the steroids for a short period, that might actually help. So this is important to tell that a few flares are not unnatural. Need to explain the management in detail, and if possible, it is almost always helpful if you can give a written care plan to these parents. Secondly, explain how to detect a secondary infection. So if the eczema is worsening and not coming under control with the steroid creams, if you can see some discharge, if you can see yellowish discharge, and it is always better to show them a picture of eczema herpeticum, because what happens is it has a very distinct look to it. It is a very dotty look. So you can see dots and dots and dots in the eczema. And the moment you increase the potency of steroid, there is no help from increasing the potency, because the eczema just gets worse and worse. So they should know how to detect eczema herpeticum. And that is a time when they need a doctor, definitely. Explain the role of environmental manipulation. So the environment of the child has to be kept cold. It has to be make sure that these children usually they are very, very averse to warm environments. So even in winters, you will see that the atopic children do not cover themselves with too much of clothes. So in the night, the parents say that they just keep on putting the cover on the child, and the child keeps on removing the covers. Keep the nails short. Secondly, in the tags of the clothes, for example, in the t-shirts and the shirts, there is a tag on the back of the neck, and you can see and again, the trousers, there is a tag on the back which probably has a company's name to it of the clothes. Just remove them, because this irritates them all the time, and you get eczema in these areas because of constant irritation. Explain the role of different medications. Answer all the queries put up by caregivers. And it is always important because every parent will have a different kind of an anxiety. So some have anxieties with steroids, some have got anxieties with paraffins. So individual anxieties have to be satisfied and give a written care plan. If I start with moisturizers, on the whole, you can see there are three broad categories of moisturizers. So one is occlusives. That means they are just going to produce a barrier on top of the skin, and this barrier prevents the evaporation of the water, and therefore it retains the water. So the moisturizing efficacy is largely because of the retained water, and there is a less of a role of the barrier on top, but that is what is producing the water to stay there. And then there are humectants. So we'll give examples in the next slide. The humectants are compounds which draw water. So they're going to draw water from the environment, and they are even going to draw water from the dermis as well, but they're going to hydrate the stratum corneum or the epidermis. That is where the moisturizing is needed. Emollients, again, some people think that that's a different category. Some people think it is part of the occlusive, because these are lipids and oils that tend to fill the crevices of the skin, and therefore they just give the skin a very soft appearance. So I would probably put them as a milder occlusive. If you look at the examples, so for example, petrolatum or Vaseline or petroleum jelly, it is just an occlusive. So it is white soft paraffin, liquid paraffin. Then you can look at mineral oils or other vegetable oils that are used by the families. Then you can see in various moisturizers addition of beeswax or silicone or lanolin or sheep wool. So these are all occlusives. So they are inert substances. They are just sitting on the skin. So that is why it is very important to put a moisturizer definitely once after bath, because after bathing, the skin has got more moisture in it. And if you put an occlusive, this moisture is not going to get evaporated, and it's going to stay there. and make the skin moisturized. Humectants are, for example, glycerol, propylene glycol, urea lactic acid, panthenol. So these are all humectants. That means they are going to draw water. So they are hygroscopic in nature. And when they draw water, they retain water there, and that water is available for the stratum corneum to absorb. So which one to use? So oils are traditional ones. So you'll see almost every family using either a coconut oil or a mustard oil or an olive oil. So it depends upon the tradition of the family. So what do oils do? So oils, first of all, they are sitting on top like an occlusive. So they are milder occlusives in nature. Coconut oil probably is the one which is time honored and being used for a very long time. With research, it has come that it is better not to use olive oil in atopic dermatitis because it reduces the integrity of the skin. So it makes the skin a bit more fragile. So there were tape stripping experiments where they put a tape on the skin and then they strip the tape, and they saw how much of the stratum corneum the tape could actually take off. And they found that the olive oil treated skin actually is more fragile than the other oils. Mustard oil, again, is something which is negatively affecting the skin barrier recovery, and therefore it is not recommended. So you can use you can use coconut oil. Sunflower oil is something which can be recommended as well. And there have been a couple of studies where sunflower oil was used in NICUs, and they found that it's something which may prevent infection as well. But there are a couple of studies from Egypt there. Then you can divide moisturizers into lotions, creams, and ointments. So that is how the division is. So what are lotions and what are... So lotion is something which is an oil in water. That means the larger base is water and you have got oil droplets in it. If you see ointments, it is the reverse. So your larger base is oil or lipid, and then you have got some water into it. And some of the thicker ointments may not have water. Why do you need preservatives? So if the more the water in a preparation, the more chances are of bacterial contamination and the more preservatives you need. So you need more preservatives for lotions and creams as compared to ointments. So if there is a stinging sensation with lotion or a cream, it may be because of the preservatives and excipients. So you can shift to an ointment which has got lesser preservatives and the chances of stinging are less as well. The problem with ointments is that it is a cosmetic issue. So in very little children, you can probably put it, but the moment they go beyond 7, 8, or 9 years of age, they stop putting these Vaselines and paraffins because they shine too much. The best compromise somewhere is the cream, which can give you an occlusion as well. And all these will probably have a combination of occlusive and a humectant to make them actually more versatile. What is a prescription emollient device? Now, the prescription emollient devices is a term which has come from the Western world because the normal moisturizers like the ointment, cream, lotion are available over the counter. But there were certain moisturizers which contained ceramides and certain substances which are thought to repair the barrier of the skin. And they are quite expensive and they needed a prescription from the doctor, and you cannot actually buy them over the counter in the Western world. And therefore, it came to be known as prescription emollient device. But these are expensive, and there are a number of studies which have shown that at the present time, any over-the-counter moisturizer pretty much works almost with equal efficacy as a prescription emollient device. So we probably will stick to our normal moisturizers. Secondly, the ceramides. There has been shown that there is a deficiency of ceramides in atopic skin. But the ceramide that we are putting in a cream are actually phytoceramides rather than the human ceramides. So there's a difference. So whether these ceramides are actually able to go into the requisite place and do the job, we don't know. So I think it's time will tell how much the ceramides are going to be helpful as a moisturizer. Now, how to use a moisturizer? So you cannot overuse a moisturizer. The more you use a moisturizer, the better you are. So frequent application at least 2 to 3 times a day. So almost you will see a child needing almost 250 grams of a moisturizer in a week's time. So liberal use. If there is a use of a jar, for example, the moisturizers can come in a tube, they can come in a jar. So if it's coming in a jar, just make sure that the parents do not put their hands into it to take the moisturizer out. Because what happens is the atopic skin is already heavily colonized with staph. So what you're doing is you are putting on the skin, you are putting your hand inside the jar and then again onto the skin. So you are probably just making that moisturizer pot a brewing pot for the contaminants. So just use a spatula to take it out on a plate or a bowl, and then you can use your hands to put it, and make sure you wash your hands before putting it. Secondly, the moisturizer should always be applied in a downward direction. So that is to ensure that you are applying in the direction of the hair growth. So if you go against the hair follicle direction, there are chances you will probably break off the hair, and eventually you might develop follicle inflammation. And if a folliculitis develops, it can be sometimes be persistent in atopic children. Secondly, apply, as I already said, apply immediately after bath at least once to trap the moisture, and then maybe a couple of times in the daytime as is needed. So bathing once daily, remove the crust, scale, allergen, germs it is needed. Just lukewarm water, short bath, 5 to 10 minutes, nothing great. Put a moisturizer after bath. Very stubborn patches, you can put a lot of moisturizer. So after the bath, so it's soak and smear is you soak the child in water and then smear with a moisturizer, and it works. Soaps we are going to take in the next slide. Bath additives and water softeners do not have a proven role in atopic dermatitis. Now, choosing a topical corticosteroid. I think even before I go there, I'll probably just discuss this. Syndet soaps are synthetic detergent soaps. Now, the normal soaps that we have in the market are alkaline soaps. So the pH of the skin is acidic. So we are born with a kind of a neutral pH, and within a few months, the pH turns acidic. And it is said that if the pH is acidic, it keeps inflammation low. The acidic pH makes sure that the skin desquamation actually is very effective. And even the ceramide concentrations are actually best in the acidic pH. So if you use regular soaps, you are making the skin alkaline. And for a short period, again, it takes time for the skin to come back to that acidic pH. And during that time, the skin is a bit more fragile. The integrity is less. So Syndet soaps are preferable in atopic dermatitis, but being expensive, I think there's a question mark. So if the expense is not an issue, then yes. Otherwise, what you can do is you can probably use soaps which have got glycerin in it. So that can act as a humectant, or super fatted soaps, which have got more fat in it and act like an occlusant, and use soap less often. The idea is actually, even though you have got bathing is once a day, but use of soap should be less often than once a day. Now, topical corticosteroid are really important. How do you choose a topical corticosteroid? So first of all, it depends upon definitely the diagnosis. So you've got atopic eczema. It depends upon the extent. So if you've got a whole arm, a whole leg, you cannot use an ointment. Ointment is very difficult to actually spread. So you need a lotion or a cream. Then it depends upon the severity. So if you've got a very thick lesion of atopic eczema, for example, on the elbows and knees, you are okay with an ointment, because that is going to stick there, stay there. And ointments on the whole are more effective than a lotion or a cream. So thinner a consistency, the lesser the potency. For example, if you look at one of these steroids like mometasone, if you use a mometasone cream, it is less effective than mometasone ointment. And if you get a lotion, it is even less efficacious. So the effectiveness also depends upon the delivery vehicle. So the potency, we'll look at the potency chart. So there are steroids which are less potent. Then they are moderately potent, strongly potent. Now, how to choose if you've got a thinner skin, for example, eyelids, face, scrotal area, the skin is very thin. So you need low potency. If you have got to put a steroid in the folds, take a low potency, because in this fold, the steroid is going to last long. So the potency increases because it's going to last a longer time. Duration of treatment and adverse effects. So if you are going to use the treatment, use it properly over a period of time, and make sure that you tell the parents that you stop the steroids after that particular time, so to avoid the adverse effects. And then there's a bit of a proper patient profiling. For example, the level of understanding of a patient. So if you think that the level of understanding is not really good, it is better not to give high potency steroids, where the chances are they're going to be used for a longer period of time. Past experience with the patient, definitely, and socioeconomic status. For example, as I said, calcineurin inhibitors are very expensive. So if you've got a poor family, there's no use actually going down the route, because they're not going to buy it. Now, these are the relative potency. So we have got hydrocortisone available with us. It is the mildest steroid. Desonide is again a mild to moderate potency. So after hydrocortisone, I would put desonide. So these two you can use on the sensitive areas. The moment you go up, fluticasone, usually it is not mentioned there, but this is a kind of a UK chart. Fluticasone is moderate potency. So you will see that you can use fluticasone. Then mometasone and betamethasone, they are kind of potent steroids. And so these are all available in India. If you think of stronger ones, as I said, ointments are stronger. So the moment you actually put a mometasone ointment, fluticasone ointment, betamethasone ointment, they are all stronger as compared to the creams and lotions, which are moderate. And two compounds, halobetasol and clobetasol, are really, really strong, probably not used in children to a great extent. Now, one has to differentiate between clobetasol and clobetasone. So sol is OL. And if you see clobetasone, that is the second in the moderate. So clobetasone is one of the mildest steroids, while clobetasol is one of the strongest. But the difference in the salt. So butyrate is milder, the propionate is stronger. So one has to make sure that you read this before prescribing. We all know the adverse effects of topical corticosteroid, but what I tell to the family is don't be on the phobic side and don't be onto the other side as well. So you will find a family, the word steroid is, we don't want to use it. And the other side of the family where they use it like that. So we have to be somewhere in the middle. They should know why we are putting a steroid and why we need to stop a steroid. So topically, if you keep on using it, you will find there will be atrophy, there will be striae development. You can see the dilated blood vessels or telangiectasia because of the thin skin thickness. You will see purpura. If you use a steroid for a long period of time around the mouth, now, even though I say long, some children tend to develop in a very shorter period as well. They tend to develop papular lesions around the mouth, which are called perioral dermatitis. And you have to take the steroid off and probably replace it with a calcium inhibitor. There will be initial flare, but then it eventually settles. So make sure you do not use steroid over a longer period of time around these areas. Rosacea is a condition where the skin becomes very, very sensitive to certain triggers like sunlight, etc. And again, is because of the use of steroids on the face for a longer period of time. You can develop acne on the face because of steroids. I think another one mentioned is masking fungal infection. So if you have got an underlying infection, for example, fungus or herpes or scabies or even a candida, they all can get masked because of the anti-inflammatory property of the steroids. If you keep on using a steroid for a long period of time onto the gluteal area, onto the nappy area, there may be development of thick areas called granuloma gluteal infantum. Again, you will need to take the steroid off. On the face, you can develop hypertrichosis with the steroid as well, and then various pigmentary changes. There's a condition also called tachyphylaxis. So if you keep on using a steroid for a long period at a particular point, sometimes the efficacy reduces. So the moment the efficacy reduces, you can probably give a gap of 7 days and the efficacy comes back. So that is called tachyphylaxis. The systemic side effects are there as well. So you get children who are exposed to strong topical corticosteroids over a larger area of the body for a longer period of time. They can even get systemic side effects of the steroid, including the HPA axis suppression. And therefore, one has to be very wary of using high potency steroids in children. Coming to topical calcineurin inhibitors, so you've got tacrolimus and pimecrolimus available. Tacrolimus, you've got two strengths, 0.03 and 0.1. So 0.03% tacrolimus and 1% pimecrolimus, they both are equivalent to a milder steroid. Whereas tacrolimus higher potency, 0.1%, is almost equivalent to a moderate to potent steroid. So almost coming to fluticasone, betamethasone kind of a thing. So when do you use calcineurin inhibitors? So first of all, the socioeconomic condition of the family should be such that they should be able to buy it. If you are suspecting a long-term steroid use the steroid topically for a shorter period and then let the calcineurin inhibitor take over. If the steroid has already started producing side effects like atrophy, switch to a TCI. Sensitive areas, for example, the face, the folds, the genital area, mostly if the financial situation is okay, just start with a topical calcineurin inhibitor. Do not give a steroid because chance of getting an atrophy in this area is very high. And then there are a few cases where the steroid did not work very well and the TCI worked very well. So you can give in those cases. The FDA has approved this above 2 years of age, and now there was a concern about the black box warning. That means that, and that came from the oral use of tacrolimus. So oral use of tacrolimus is largely in the transplant arena. And there, if you give tacrolimus, there is a higher chance of developing secondary malignancies like lymphoma and non-melanoma skin cancer. But recently, the Cochrane review has actually almost taken that doubt out of the mind. And the Canada is the first country which has taken this black box warning away. That means that they do not mention onto the brochure anymore that this particular product causes a secondary malignancy. So I think with time, probably that is going to be taken off. Other important issues I'll just very quickly go through is a secondary infection. So the moment you are suspecting a secondary infection, topical steroid increase in potency is not going to work. Topical in antibiotics usually do not work very well and always carry a risk of sensitization. So always give an oral antibiotic covering staph or staph and strep if you think so, and do not rely on topical antibiotic. If there is a very mild discharge and you think there may or may not be an infection, just a topical steroid actually settles the scores. So here you can see the vesicular lesion. So this is herpes simplex infection on top of the eczema. So one has to make sure that the moment one sees these dotty things, either they are vesicles or they are just dots, think of eczema herpeticum. If a child is systemically well, just an oral acyclovir would do. But if child is systemically unwell, you will need an intravenous acyclovir. This is varicella zoster or chickenpox developing on eczema. So you can see umbilicated lesions. So umbilicated means as if there is an umbilicus on top of the lesion. So there's a central depression. So again, varicella and herpes simplex in children with atopic eczema can rapidly spread. So one has to be sure that one starts antiviral as soon as possible. And if the child is unwell, then definitely will need an intravenous form. Second is food allergy. There's always a big question, should we check for food allergy? Not every child with atopic eczema needs to be checked for food allergy. If there is a history of immediate reaction, for example, the child took milk and had an immediate rash, urticarial, or an immediate kind of other responses, for example, GI responses or respiratory, definitely you curtail that food and think of a food allergy. Or if a child has got persistent eczema, despite the treatment being optimized, especially facial, presenting at very young age, if you have rationalized the treatment and still the eczema is not settling, think of food allergy. So what has been said is that in mild to moderate eczema, do not test for food allergies. They're going to come, even if they come as positive, they may not be significant. But in moderate to severe eczema, about 25 to 30% will have IgE-based food allergies. Some children, when they test for all the treatment, that the investigation that you do is known as the IgE-based RAST or ELISA or immunocap. There are various methodologies which can be used. What they are looking for is specific IgE against specific foods. They can be positive, but significant. They may not be relevant clinically. So how to differentiate? So the best thing is to keep a food diary, first of all, and see if that helps. Many a time what happens is there is a non-IgE based allergy. That means the IgE is normal, but still you think, and the parents say that since we have started that particular food, the eczema has worsened. Now, because there is no immediate reaction, the positive predictive value of the history becomes very low. It becomes very difficult to establish a cause and effect. In that case, a 6 to 8 week elimination diet of that particular food is helpful, but make sure that you include a dietitian to ensure there is no growth retardation or no deficiency as such. Now, specific IgEs, when you do it with the blood, have a better negative predictive value. That means if they are negative, you can rest assured that this food is not causing an issue. But when they are positive, you have to corroborate with the history. And again, you have to just eliminate for a shorter period of 6 to 8 weeks. And if it does not make a difference, make sure you reintroduce that in the diet again. Skin prick testing, again, you have got a better negative predictive value than a positive predictive value. Atopic patch test is using a patch test for it in atopic dermatitis. It is not validated, so it is not indicated. The gold standard is for immediate reactions is a double-blind placebo control, which is again very difficult to do in children. Now, as I said, elimination diet is diagnostic for non-IgE based, but it is not empiric. It may lead to nutritional deficiency. It may affect growth and development. Therefore, do not just do it like that. Just make sure that the parents know what to eat to make sure that the nutrition is maintained. Third is contact dermatitis. So if you've got a patterned reaction, for example, here, there is one eczema patch which is not coming under control. So this probably was because of the belt buckle containing nickel, which is causing a contact reaction. So there can be an allergic contact dermatitis or ACD to nickel, to fragrance, perfumes, even neomycin. So that's where the topical antibiotic cause an issue. Preservatives can cause an issue. Even topical corticosteroids can cause allergic contact dermatitis. So how to differentiate? If you are putting a moisturizer, if you're putting a steroid, the things improve temporarily, but then they worsen even when you're using them. Think of an allergic contact dermatitis and get a dermatology liaison who can do a patch test to rule out a contact reaction. Growth, sleep, and psychological input is really important and needs to be inquired on every visit by the family. If the child's food, there are families who have curtailed certain foods just on their own, and that may affect the growth. Just the eczema, generalized eczema being a chronic inflammatory condition, can affect growth. Secondly, sleep. If sleep is hampered, the whole family's sleep is hampered, and that can cause disharmony in the family as well, plus absenteeism from the school. Again, there are certain children, because they are so much the eczema is causing so much of problem that it becomes a psychological issue, and one may need a psychological input as well. So not many slides left, so a couple of slides, just the criteria for initiation of systemic treatment. So if you have got a child who has got eczema, but there's a severe resistant disease, despite rationalizing the treatments, the disease is quite widespread, the child is steroid dependent. Either it is a topical steroid dependent or an oral steroid dependent. It is affecting school relationship or personal relationships. There is a psychological affliction. Then definitely there's a criteria that we need to start systemic treatment. Now, oral steroid, I've already considered that it's a short-term bridging therapy. What is a systemic treatment? So one is phototherapy. Now, phototherapy does not help with acute eczema. So if you've got a chronic eczema, phototherapy is helpful. Another therapy which can be helpful is called wet wrapping. So I don't have a slide for that, but what is wet wrapping? So for example, if you got severe eczema on the arms and legs and you have tried using the steroids and the things are not coming under control, instead of starting the systemic, one can do wet wrap therapy. That means after the bath, you pad dry the skin, put the moisturizer, then we put the steroid on the affected area, and then we put one layer of wet clothes which are wrung out. So jo tight kapda cotton ka aap nichod ke, and then you just let the child wear on that area, and then you put a dry cloth on top. So on the top, he can put a dry t-shirt. That is called wet wrapping. Because of the moisture, there is an increase in the effectiveness of the topical preparation. So you can use that wet wrapping for 1 to 2 hours, 3 hours, and take it away. And even if you do it a couple of times a week, the lesions resolve sometimes quite nicely. As far as the systemic treatment is concerned, the systemic treatment is in the form of systemic immune suppressives, and they are usually, the most common one used is methotrexate. Again, it will need follow-up and monitoring. So that is the least expensive, time-honored, and most people have got a good experience with methotrexate. Azathioprine is another one which can be used. The only one which is FDA-approved systemic immune suppressive for atopic dermatitis is cyclosporin. So cyclosporin works very well. It acts very quickly, so you may not need an oral steroid when you're using cyclosporin, but one needs oral steroid short period, few weeks, if you're using methotrexate or azathioprine, because they have got a latency of 4 to 6 weeks to act. Cyclosporin can be easily used up till about 6 months or maybe an year, but then you will have to stop. And again, it recurs, you may have to think of switching to some other thing. Mycophenolate is kind of an alternative which can be used. So in the Q&A, again, there was one question about crisaborole. So we have got 2 topical preparations now, crisaborole, which is a phosphodiesterase 4 inhibitor, and we have got tofacitinib, which is a JAK inhibitor or Janus kinase inhibitor. So these 2 have come up recently in the past 1 year or so as possible topical applications. which can be used in areas where you do not want to put a steroid on. Again, expense is one thing. Crisaborole again is for mild to moderate eczema. So it will be almost vis-a-vis tacrolimus and pimecrolimus. So that is something, again, it is expensive one, so that can be used instead of a steroid in these areas if monetary issue is not there. Even oral JAK inhibitors, known as like tofacitinib, is being used in atopic eczema. At present, the licensing is there only for a limited age groups, but I'm pretty sure in times to come, you probably will see tofacitinib, abrocitinib, and other JAK inhibitors making their way for. But again, that arena, you will need a dermatologist liaison for treating atopic eczema. So when to refer, if there is a diagnostic uncertainty, refer. Severe atopic eczema, recalcitrant atopic eczema, and if you think that there is a need for systemic immune suppressants, then definitely you need a referral to dermatologist. As I showed the contact eczema on the abdomen, if you're thinking of a contact allergy, contact a dermatologist for a patch testing. If there's recurrent secondary infection or if there's a significant social and psychological problems, then definitely refer to a dermatologist. So in summary, what I would say that atopic eczema is more than skin deep. Every child, every family is different. So you will need to customize the thing. And there are, with the research which is going on, I think in coming years, you will probably get a precision medicine. That means you might look at the genetic makeup of a child and say that this is a drug or this is the thing which is going to work and this is not going to work. For example, there are approaches where they have seen that if it's very high IgE, you can give an anti-Ig like omalizumab, even though it was shown not to work very effectively in many eczema cases, but few cases of high Ig responded very well. So you will probably reach the place where precision medicine will be there. If there is no response with your therapy, do not just keep escalating. Take a step back and think there might be something else like a contact eczema or a food allergy or a secondary infection. You need a family-oriented approach and do take help of the dermatology colleagues when there is appropriate. So that is where I stop. Thank you.
Thank you, sir. Sir, can you please share first two slides because many people missed it. First two.
Yeah.
Thank you, sir.
I'm really sorry. I think there was a bit of a problem with the internet connection there.
Yes, it happens once you're traveling.
Excellent session, sir. And I think there are hundreds of questions in the chat box.
Let's see.
Vijay has
just see the two slides. Actually, this is the atopic dermatitis. It was a criteria. I think we discussed the criteria, and this is I think the most simplistic criteria, that it has to be an itchy skin condition to say it is atopic eczema. And you have itchy skin condition plus 3 or more of the following. So you get either the onset is below 2 years of age, and then there's a history, either history of dry skin in 12 months, history of other atopic conditions, history of flexural dermatitis, or on examination, you can see flexural dermatitis. But if a child is less than 18 months, then even cheeks and extensors would do. And I think this was the only slide where we started, like atopic dermatitis starts in infancy with cheeks, and then it gradually makes its way towards the extensors and then the flexures. But napkin area always remains spared. So that is the hypothesis is that it is because it is moist, it remains spared. Should we take the Q&As?
Yeah, yeah. So I'll take up some questions. So do you recommend antihistaminics below 6 months of age?
Sorry, can you say it again?
Yes, sir, please stop sharing the screen.
Yeah, just a moment. Oh, there we
go. So do you recommend
antihistaminics
below 6 months?
I think there are many people speaking at the same time. So
okay, sorry. So do you recommend antihistaminics below 6 months of age?
I think antihistamine below 6 months of age, I do use hydroxyzine sometimes, but most of the times if you put a steroid on, the itching usually settles within a couple of days. So most of the times you don't need it.
Okay.
Sir, you can switch on your video, sir.
Yeah.
Thank you. Thank you, sir. And so what is the rationale of phototherapy?
So phototherapy is, again, it produces a localized immune suppression, and it's an anti-inflammatory at the same time. So, but the narrowband UVB therapy is now recommended, which is the safest of the lot, and has been shown to have minimum mutagenicity. So that is the one which is used, and usually 6 to 8 weeks of phototherapy. And secondly, it also acts like a preventer because the whole skin gets exposed. So it is not only acting on those plaques, but acting on the surrounding areas as well.
Does it not darken the skin?
Usually, no. I mean, it's a short lasting phototherapy, only a few minutes. So even
Okay.
though dryness of the skin, pigmentation of the skin, they are there as side effects, but mostly you don't see much.
Somebody has asked about castor oil. I don't think castor oil is applied on the skin anywhere. Am I right?
You can see it on the internet, but it is not one which has been studied for atopic eczema.
Okay. So what is the frequency of application of moisturizer? So in the morning you have a bath and within 5 minutes you apply the moisturizer. That is the first application. Then how do you recommend multiple applications like in the afternoon and in the evening or something of that sort?
Yeah, I think if you use it 2 to 3 times a day, the child is much better moisturized because usually it doesn't stay for long. So even though you see you see preparations where they say 24 hour and 48 hours moisturizing, it doesn't happen because when you wear clothes, it just gets wiped off. So I think at some point, and each child is different. So you will have a child needing it 3 or 4 times a day. You will need you will have a child who is twice a day is fine.
सर एक इंडियन ट्रेडिशन होती है कि वो बच्चे को सुबह सुबह मालिश कर देते हैं और फिर नहला देते हैं, तो इज दैट गुड और इट शुड बी अदर वे अराउंड कि पहले नहलाओ फिर मालिश करो?
It should be the other way around. I think once you have actually put the oil on, then the water is not going to seep in.
यस सर.
Yeah. What is the management of eczema herpeticum? Somebody has asked this question.
If the child is systemically well, oral acyclovir for 5 to 7 days, and if the child is systemically unwell, then definitely you go down the route of intravenous acyclovir. Topical moisturizer, you probably just take away the topical steroid for a couple of days. Some people prefer taking it away because there's an infection there. Some people prefer not taking it away, but just introducing an antiviral. So what I do is I usually stop the topical steroids for a day or two, put the acyclovir in, and after a couple of days, because you will need topical steroid for the eczematous process, but you need it under cover of the acyclovir.
Okay. And any role of sunscreens?
Not as such. Not as such. For atopic eczema, you don't need sunscreen unless you have got photo-aggravated eczema, which is not very common. And that usually happens only on the face and exposed areas. And there, if you need a sunscreen, usually in children, the children's sunscreens are usually physical sunscreens. So they just have zinc oxide, titanium dioxide. Mostly it is just zinc oxide. So you will not have chemicals in most of the sunscreens for children.
Okay.
Sir, should the JAK inhibitors be used by pediatricians or by the dermatologist?
I mean, at the moment they are being introduced to the dermatologist. I don't know if the people have come to you as well for the.
No, because there are many questions regarding the JAK inhibitors that you have discussed about. I think these should be limited to dermatologists only.
At the moment, yes, I think till, for example, tacrolimus, when it came around as a dermatology product. Now everybody is using it because all are comfortable with it. So this is something which is very new. I think let the dermatologist see whether it's of use or not. For example, crisaborole, some people find it very useful, some people don't find it useful. So only time will tell in another 6 months, 8 months whether it's going to actually.
Because there should be certain options left to dermatologist. Because
Yes.
if you use everything, then what will the dermatologist?
I think I'll give you an example. For example, in fungal infections in adults, I'm not doing in children. In adults and fungal infections nowadays, for superficial infections, you need around 3 to 6 weeks, sometimes 8 weeks of itraconazole. So if a person who is not a specialist is using, for example, at the RMP level, they give itraconazole 7 days.
7 days.
Then they stop. So that is one thing which has increased the problem of resistance. Again, topical steroids, if you don't use it for 7 to 10 days, it doesn't actually help. If you use for 3 days, then give a gap, again use for 3 days, it just keeps on happening. So if you use it en bloc, then the chances of having a persistent suppression of that flare for a longer period of time actually is there.
That was the next question, in fact. So this is very important. What is the duration of local topical steroids? You have already answered it, at least 7 to 10 days, 2 to 3 times a day, if I'm right, for products like
It
Betasol.
used to be 2 to 3 times. So recent studies have shown that even once a day actually works equally well. So nowadays we have just gone down to once a day.
Okay, but we pediatricians say that hydrocortisone application is required at least 2 to 3 times a day because normally it is children and we want a milder steroids. We are afraid of using products like mometasone on face. So
yeah, on the face, I would not prefer mometasone. Hydrocortisone is absolutely fine. You can probably hike to desonide if there is a need for a shorter period of time. But again, 5 to 10 days. I mean, there is no hard and fast rule why you can't use twice a day. Mometasone was one steroid, which was the first one to show efficacy on once a day application. And since then, the studies have come and they have shown that even once a day. So it depends upon, I think, case to case basis. You can use twice a day hydrocortisone, that's fine. but 5 to 10 days is what you will need. But if you're needing it again and again, think of calcineurin inhibitors on the face.
So many MRs are coming with probiotic sachets that these are very useful in atopic dermatitis. What do you find? Many MRs are promoting this.
The one probiotic which has shown some efficacy is Lactobacillus rhamnosus GG. So that is where the study is there. But still, if you look at the Cochrane reviews, they still have a question mark on the probiotic. So we don't have an evidence per se saying that we don't have an RCT saying that we give probiotic, we don't give probiotic, what happens? So I think we still need answers to the question that how does it help? So there have been studies where now pregnant women are being given probiotics to see if the children actually in significantly atopic families, whether the child can be protected against atopic eczema. So I think we still need more time. So at the moment, we don't have sufficient evidence to say that probiotics help. But gut dysbiosis has been shown that in atopic dermatitis, children can have gut dysbiosis. So whether improving that can improve the Th2 responses. So that is one question. So I think we need more time before we can put it as a sure shot therapy.
Sir, as the disease starts very early in the age, are there any options being considered in the intrauterine life, like during pregnancy? During pregnancy, we can
do something to prevent atopy if the
onset
family
of-
is prone to atopic dermatitis. So this is something which is being thrown around nowadays in our conference.
Probiotics is one thing which is being studied, and definitely breastfeeding a child after pregnancy, definitely breastfeeding a child is something which is said to be preventive. And now there are studies of putting moisturizer from as early as possible. So there are a few studies which have shown that if you start using a moisturizer very early on, it is going to help prevent atopic eczema, and it may prevent atopic march, so that they may not develop allergic rhinitis or asthma. So even though recently, 2021, there was a Lancet study which showed that it probably was not the case. So I think it is out in the jury, but that is one way probably which is way forward for prevention.
There are lots of questions on the variety of mixtures being used as emollient. Somebody said rose water with glycerine, with some coconut oil and all that. So I think we need a clear message from you that not to experiment with these products, or if you want, you can give some whatever message you want to give on this.
Any good emollients and moisturizers?
I think just use coconut oil is a mild occlusant. So if you have got mild dry skin, it does work. So if you have got significant dry skin, then you will need a cream on an ointment basis. So that is what is needed. Secondly, don't mix the products because we don't know what the profile of that product is once you've actually mixed it. So some people think that if they mix a higher potency steroid with a moisturizer, they are producing a low potency steroid. That's not the case. So you don't know what is happening there. So it is still acting as a high potency steroid. The only thing it might act on a specific area, how much to mix, what is the proportion? I think there are many unanswered questions in that. Secondly, I think as a dermatology organization, we are already fighting this fixed drug combinations. So where you mix where you have a mixture of steroid and antibiotic, steroid and antifungal, because once you start using it, you just keep using it. So if they come as different tubes, I think the use of steroid probably will go down in many areas where it is not needed, and the use of mixture will go down in areas where it is not needed. For example, in atopic eczema, the use of unnecessary topical antibiotics can cause contact sensitization. So if you just have a single tube, then the chances are actually less.
Because I remember one of the dermatologists or somebody telling me that steroids should always have antibiotic in it if you are using it for more than 4 to 5 days. So I was a bit surprised that will it not lead to resistance finally? But he said in steroid ke saath you should have an antibiotic mixed in it.
No, never. Just a topical steroid for the flare, and most of the times it has been shown that even if the staph colonization is there, just reducing the inflammation has taken away the colonization. And again, I think using maybe something like fusidic acid is still okay. But with mupirocin, you are finding increasing resistance to mupirocin nowadays, just because of extensive use. And now we have got this ozenoxacin. I think if we use it left, right, and center, we are going to get resistance to this as well, because we need mupirocin and ozenoxacin for MRSAs.
Yes, you're right. So I think rational use of antibiotics everywhere, right from pediatrics to medicine to general practice to dermatology is extremely important, or we will land into a post-antibiotic era where nothing will be left for us to use.
Absolutely.
Dr. Rajay, any more questions from the chat box?
I'll just promote one or two delegates. Dr. Devika, you want to ask something? Dr. Devika?
So meanwhile, when Dr. Devika is
So
coming
can you
on,
just name a few
Sir,
good...
I'm Dr. Vidya.
yeah, Dr. Vidya,
Yeah,
please.
good morning, sir. I'm Dr. Vidya. Basically, I have answered more or less all the questions. People want to know about wet wrap therapy in atopic dermatitis.
Yeah, that's what I wanted to say. Wet wrap, how do you do it? How long do you do it? What areas can you use? Some people are using face masks for wet wrapping on face, but these face masks are coming with lots of additives like aloe vera and I don't know what all things are there. So what varieties of masks can be used and how to do it?
I mean, I have not used wet wrap on face. I mean, you don't need it on face. If you got significant eczema on face, you need to think of why it is happening, because it is not a very common area. Mostly, you will see it it used to be known as the wet pajama therapy. So that means that on the body, if you got eczema and you are thinking in terms of putting on a systemic immune suppressant or something, many times what you do is in wet wrap therapy, you basically soak the child in water. That means you after the bath, you pat dry so that some water remains. Then you put a moisturizer all across. And then you put a steroid. You use a lower potency steroid because once the occlusion is there, the potency increases because it is going to stay there for a while. So you put a low potency steroid on the affected area, and then you one layer of wet clothes and then one layer of dry clothes. So that is called the wet wrapping therapy. So the wet clothes, you put them in lukewarm water and then you wrung them out, pura nichod do unko, and then you actually wear them, and then you put one layer of dry ones. 2 to 3 hours per day, 2 to 3 times a week, sometimes actually does wonders. And you can use it even on a localized area. For example, you got resistant eczema on the hands, resistant eczema on the elbows. You can just do the same therapy on a localized area. So that is how it works.
So is sunlight a friend or an enemy of atopics?
Mostly it is a friend. I mean, it's a phototherapy again is kind of a fraction of a sunlight. So it is a friend. But if you have got nowadays, what you see sometimes in adolescents is you're using a lot of steroids on the face. If they develop steroid rosacea, then sunlight becomes an enemy because they can't be in sunlight for long. It causes erythema and stinging and all that sorts. But mostly, I will say for atopic dermatitis per se, sunlight is good for you.
Okay, so any time of application of steroid, like applied at night or like same with tacrolimus also. I think tacrolimus is some amount photosensitive.
Tacrolimus, the original papers are all twice a day application, but I think we have got intense sunlight here. So I tend to apply only in the night time. Steroids, again, you can use any time that you want, but again, nighttime is easier, so I prefer night times.
Thank you, sir, for a wonderful session. I think we have answered most of the queries. Most of the queries are related to the brand names of the emollient and moisturizer. Can you name one or two good
I think it's better not to name.
Yeah.
Okay, sir.
I agree
No
with sir
problem.
because
No
not good to name because
Yes.
anybody else will feel I am left out. There
Yes,
are
sir.
around 20
Yes.
brands.
And
Then you may get an endorsement from the IAP. That becomes very issue, sir.
Yeah, I agree with that totally.
Yes.
And thank you very much, sir, for a wonderful presentation and wonderful discussion. We are really honored to have you with us, and it was a great session. Thank you, sir.
Most welcome, sir. It's my pleasure to be here. Many thanks for a wonderful morning on a Sunday.
Yeah,
Thank you,
and dermatology sessions
sir,
are
do
always
visit,
houseful.
Garden of Five Senses.
Great. Thank you.
Dermatology sessions are always houseful. So many queries and it's really
and
lovely.
they always remain unanswered. I think few queries are unanswered. So
Yes.
That is life.
So, absolutely. So every week you have them. So somehow Atopic is going to come back again in all the lectures, I'm pretty sure.
Oh, yes, sir.
And we thank Dr. Vidya Yadav also to answer many of the questions and moderate this session. She is a senior at Lady Harding Medical College in Dermatology Department.
Thank you very much, Dr. Vidya.
We request
Thank you, sir. Thank you.
Sir, please say about the upcoming program of IPT.
Dr. Bhandari, please. Dr.
Sir,
Bhandari, please unmute.
Sir, please unmute. Sir, please unmute. Right.
Well, friends, I invite you all to please join for our next a very important online education program on type 1 diabetes mellitus. I think you must have received details on your WhatsApp and through various groups and email also. We have a distinguished faculty headed by Dr. Rajesh Kadgawat from AIMS, and it will be another learning initiative from IAP Delhi. Please do join. And dermatology to jitni kam baat kare utna acha hai. I think it was a very interesting, absorbing session, and looking forward to further happy Sundays over the next 2 months. Thank you.
Thank you, sir.
Okay,
And
sir.
thank you once again, all the delegates also. If there's more questions, you can post them to us. We'll get them answered. Thank you so much.
Okay, thank you. Have a lovely day. Thanks.
Thank you. Mr. Sushil, please close.